So straight away we can start the session. First I call upon Dr. Dhanya for her talk, how to interpret a normal OCT.
Thank you, ma'am, for this opportunity. So this class is how to interpret a normal OCT. OCT has revolutionized the diagnostic field of retina. It is actually an in vivo optical biopsy, and the spectral domain OCT gives high resolution, accurate imaging of the retinal layers. These are the various modes of OCT that we had. Now presently we have the spectral domain OCT and the swept source OCT. It gives you a qualitative analysis as well as a quantitative analysis. It helps in identifying the anomalous structures, the location, form and structure of the lesions and reflectivity of the layers and lesions, as well as you get a thickness and volume measurement. Now, considering the location, it could be a pre-retinal, epiretinal, intraretinal or subretinal and sub-RPE, and the reflectivity depends on how much pigment it contains and whether the orientation is horizontal. So if there is more pigment, more horizontally oriented, we get hyperreflective, which are white or bright. Now this is the OCT nomenclature. The most important thing that when you have to remember when you look at a normal OCT is that the four hyperreflective outer retinal layers. The most important is the RPE Bruch's membrane complex, then the external limiting membrane, the ellipsoid zone and the interdigitation zone. In the inner retina, we have the hyperreflective layers, which are the neuronal layers or the plexiform layers. The nerve fiber layer, the inner plexiform and the outer plexiform layer. Now, based on reflectivity, that is how you identify the lesions as well as the normal structures in OCT. The high reflective lesions are pigments, scars, hard exudates, drusen, hemorrhages, all these are hyperreflective. Medium reflectivity is for retinal edema, fibrin and posterior vitreous, and low reflective is fluid or vitreous. As in the picture, you can see the hyporeflective cyst and the hyperreflective hard exudates. Now what is this? This is shadowing. Suppose there is a hyperreflective lesion or in the inner layers, it can produce a shadow onto the posterior layers. That is called shadowing, which usually we find when you look at hard exudates. Now this is reverse shadowing or windowing, that when there is a large area, as in case of an AMD, when there is a large area of geographic atrophy, you can see that the choroid is more visible. This is called windowing or reverse shadowing. What is this picture? This is asteroid halosis casting its shadows on the retinal layers. In qualitative analysis, when you look at an OCT printout, you have a macular cube or the ETDRS grid, which gives measurement of certain areas of the macula. It is divided into the central subfield, which is 1 millimeter, the inner macula, which is 3 millimeters, and the outer macula, which is 6 millimeter. And the thickness of this is measured from the internal limiting membrane to the retinal pigment epithelium, which is given as a value on the OCT printout. These are the scan protocols that you have in spectral domain OCT, the macular cube, the radial line scan, and the high definition raster scans. These are few images from the Cirrus OCT. You can see both macular cube and the high definition images. Spectralis gives a more wider view and a 3D volume scan of the posterior pole. Atlantis pictures. Now, when you have an OCT printout in your hand, it's always important you analyze the OCT from the machine itself. But if you are getting a printout, look at the patient details, the eye, the dates, if it is a serial scans, confirm the signal strength, at least 6 out of 10 is present, and is the image well centered on the area of interest. A printout in hand. First you have, this is the LSO fundus image with the ILM RPE retinal thickness map overlay, the ETDRS grid, the OCT fundus image, the OCT image which showing the horizontal crosshair line and the vertical crosshair line. You also have the 3D macular thickness map showing the retinal thickness in a topographical display, a segmented ILM map and a segmented RPE map, plus the macular parameters compared to the normative data. These are the high definition images. You also get a macular change analysis report. This is very useful when you are following up a patient which is treated. You may also get a single eye summary like this, where you have both the macular analysis as well as the ONH RNFL analysis. Now, for reading a normal OCT, always look at the normal, look at the vitreoretinal interface, whether it is normal, the foveal contour, whether the layers of retina has a normal morphology, ellipsoid zone, and the RP Brux membrane complex. These are various OCT reports. We'll have a detailed discussion later. And OCT is very important in diagnosing, treating, and following up patients with diabetic macular edema, AMD, as well as and various other conditions, macular conditions. A word on optic nerve, RNFL OCT. It is very important for the management of glaucoma. It is an important adjunct to visual field testing in the treatment of glaucoma, especially in pre-perimetric cases. It can track the optic nerve edema as well. And this is the RNFL OCT and ONH OCT printout. The key parameters result will be given in the center compared to the normative data. This is the RNFL thickness map. So if we have an hourglass shaped map with yellow and red colors, is typical of normal eyes. The RNFL deviation map, the NRR thickness profile, the TSNIT graph, which give you the average thickness, the horizontal and the vertical B scans, and the RNFL calculation circle.